This conference will now be recorded.
Hello everyone and welcome to the session today. So today we will have a short session. It's mainly about laparoscopy, but we will start first by talking about some surgical instruments. And surgical instruments may come as a part of core surgical skill station. Usually it will not be a separate station. It will be within another task, like in hysterectomy or laparoscopy. So we'll start talking first about most of the surgical instruments that can come in the exam. And after that, we'll discuss about the laparoscopy and do another two stations on the laparoscopy. So when we are facing a station of a surgical instrument in the exam, it's important to do 2 points. The first thing is you need to handle the instrument correctly, and you need to describe this instrument properly. It is not important even to know the name of the instrument. You will take the mark mainly for your proper handling technique and for your description of the instrument. And on the other hand, if you rush and talk only about the name of the instrument, unfortunately, you will not gain mark for that. So when you find an instrument on a scrap table, first take it and handle it correctly as in the first picture. To handle it correctly, you will insert the thumb and the ring fingers into the ring of this instrument, using only your distal phalanges. And your index finger will steady the instrument by placing it over the joint. As in this picture, you can see only the distal phalanges of the thumb and the ring finger, while the index is steadying the instrument. After handling it correctly, you need to describe the parts of this instrument. So finally, you can determine what type of this instrument is. So how to describe this instrument? You need to describe about the handle, the shaft, the tip, and the jaw. Holding the instrument and look for its handle and see this instrument has a handle and determine if this handle has a lock as in this picture or doesn't have a lock, and if the lock is rigid lock or not. Then go to describe the shaft and determine if the shaft is straight or curved. Then open the instrument and look at its tip and see if the tip is toothed or non-toothed. And the last is describing the jaw. The jaw is this part you need to determine while opening the instrument. If the jaw contains longitudinal ridges with corresponding grooves, I mean that it's a crushing instrument, like a clamp, or it has a non-opposing jaw, as in Volzellon. So by describing this part, you can finally reach the name of this instrument. So again, to determine the instrument, handle it correctly, as in this picture, describe its part, the handle, if there is a lock or not, the shaft, if it is straight or curved, the tip, if it is toothed or not, and finally the jaw, if it is a crushing jaw or has a non-opposing jaw like tissue holding instrument. Let's apply this to this instrument in the picture. I'd like one candidate to start describing with me the following instrument. So let's start by Dr. Sharada.
Hello, doctor. Good evening.
Good evening, doctor. So I'd like you to identify this instrument and describe it for me and tell me about its uses.
Identify, describe, and tell its use. Okay. Hello, I'm Dr. Shraddha, one of the exam candidate. I'm happy to start my structured discussion. The instrument in front of me is this is an Ellis forceps. It has a handle, and then it has a lock, which is a ratcheted lock. Then it has a shaft, which seems to be a slight straight or slightly curved to me. I cannot appreciate at this stage. Then there is a box lock.
Straight or curved?
It seems to be curved to me. I cannot
Yes. Okay.
It is the shaft is curved. Then it has a tip. Then it has a tip, which is toothed, and then it has tip which is toothed. Yeah, and the
What about the
jaws are
jaw?
opposing. I think the jaws are opposing. It is made up of stainless steel. It is used to hold tissue structures like rectus sheath and some angles of the uterus also sometimes. And I will hold this with my two. I hold my the Ellis with 2 fingers. That is just I'll with my thumb and the index finger I'll hold my Ellis.
Okay. So, try Dr. Sharda, don't trust to the name of the instrument. To follow first, as I told, about description to reach the name correctly. Okay? So, as you can see, this instrument, first try to hold it correctly while your thumb and ring within the rings of this instrument and the index steady this instrument. Then describe it. I have an instrument with a handle, with a lock. It has a curved shaft. It has multiple tools tips. There is a non-opposing jaw, so it's a tissue holding instrument. And as you can see, it's a curve. It contains the anteroposterior curve of the pulsellum. It's a pulsellum instrument. You can differentiate it from the Alice. Alice don't contain the anteroposterior curve. So this is a pulsellum. And for uses, we can grasp the cervical lip to visualize the cervix. It could be used in vaginal hysterectomy. Also, you can use it to grasp the typhoid polyp. So let's move to this instrument, identify it to me, and tell me which one can be used within the peritoneal cavity.
Yeah. So this is tissue holder forceps. There are 2 types. One is the tooth, other is untoothed. It has 3 parts. It has a hinge joint. Then it has a shaft, which has transverse serrations, so that we can hold it there with the fingers, with my index and thumb. And then it has a jaw, which is the tooth one that is this is used to hold tough structures like rectus sheath. And the
Which
other
one
one
can
is
be used to hold the rectus sheath? Which one, the toothed or the non-toothed?
the tooth. The tooth one is used to for holding tough structures like the rectus sheath, and it is made up of stainless steel. The other one is non-tooth tissue holding forceps, and it has also the same, the hinge joint, the shaft, and a tip. The tip is non-tooth, and it has transverse serrations, I can see. It is used to hold soft structures like peritoneum.
Okay. So there is the toothed and non-toothed forceps, and you can handle it correctly as in this picture with your thumb and the forefinger like a pencil. And the toothed one is used to grasp the thick structures like the skin and the rectus sheath, but within the peritoneum you use the non-toothed one because it is less traumatic. So describe this and identify its uses.
So this is a needle holder. It has 4 parts. It has the handle for inserting 2 fingers. That is, I will insert my thumb and the ring finger with it, and my other 2 fingers. The index finger will be pointing forward. Then it has a shaft which is straight. Then it has a jaw. Jaw which has transverse or oblique serrations, and there is one depression also to hold the needle, and then it has tip which is non-toothed. It is made up of stainless steel, and it is used to hold the needle at the junction of 2/3 and 1/3. It can be used to suture rectus sheath, uterus, the stumps.
Okay, so it's a needle holder, and you need to handle it correctly, as in this picture. And as you described it correctly, it has a handle with a lock. It has a straight shaft non-toed tip, and short jaw. And this is the characteristic of the needle holder. You can see the jaw is short to avoid mistaking it with the clamp of the hysterectomy. Here, the crushing jaw is short. So the jaw also contains longitudinal ridges and corresponding grooves, the crushing. So it's a needle holder to allow maneuver with the needle through various tissues. So identify this instrument and describe its uses.
Yeah. So this is LS tissue forceps. It is used to hold tough structures like rectus sheath and uterine angles.
Describing it, please. Describe, then tell the names, and tell the uses.
Okay. So then it has a handle with two holes to insert two fingers. Then it has a lock, which is ratcheted lock. Then it has a shaft, which has box square locks. Then it has a tip. Tip. It is toothed. It is toothed so as to hold the tough tissue structures. And the two jaws are opposing. And it is used to hold rectus sheath. Then it is used to hold the uterine angles, and also it is used in vaginal hysterectomy also when we are reflecting the bladder.
Okay, so correctly you describe it that it has a handle with a lock, it has a straight shaft, it has a multiple fold tip, and there is a non-opposing jaw. It is named a non-opposing. Opposing means that they are adjacent to each other. It's a non-opposing. There is a space between the jaw. And this is named Alice forceps. And as I said before, the difference between the Alice and the Bolzellum is the anteroposterior curve, which is present in Bolzellum, but in the Alice, it's a straight instrument. And its uses holding the anterior lip of the cervix, holding the edge of vagina during hysterectomy, hold the rectus sheath in abdominal surgery, and you can use it to grasp the ovary and tube ovarian masses in ovarectomy. So identify this instrument and mention its uses.
Yeah. So this is green Armitage, and it has a handle to insert two fingers. That is the thumb and the ring finger. Then it has a ratcheted lock. It has a shaft which is straight with a box square lock. Then the jaws. It has a jaw which is non-opposing, and the tip is slightly toothed, almost, or we can say it is transverse serrations are there.
Yes.
And it is used to hold the uterine angles when there is bleeding.
Yes, that's great. So,
and it is made up of stainless steel.
Okay, so this instrument has a handle with a lock, straight shaft, non-fold tip with a non-folding jaw, along with horizontal serration in its lower part. There is the green Armitage uterine forceps, which is used to hold the uterine edges at the cesarean section and can be used on each side of the uterine incision angle. Identify this instrument and mention its uses.
Yeah, this is sponge holding forceps. It is used to. It has a handle. It has a lock, which is handle to insert two fingers. That is the index and the ring finger. And then it has a lock, which is ratcheted lock. The shaft. It has a long straight shaft. Then it has the tip. The tip, there is fenestrations, and there is also transverse serrations. This is to hold sponge or gauze. It is used to hold cotton or gauze while draping the skin. Also, during hysterectomy, it is used when we are reflecting the abdominal hysterectomy. It is used when we are reflecting the bladder fold. That is, we'll put a gauze on this and press the bladder fold downward to separate it from the cervix. It is made up of
Yes.
stainless steel.
Yeah. So correctly, this contain a handle with a lock, straight shaft, and it has a small transverse groove in the lower part. So this is a polyp forceps, which can be used to grasp the uterine polyp, a bulging edge during polypectomy, and we can apply swab on the stick to clean and prepare the skin, clean parabolic gutter at cesarean section, and gently manipulating the bowel. So identify this instrument and mention its uses.
It looks like Babcock's forceps.
Yes. Yeah.
So it has a this is a forceps. It has it has, in the handle there are two circles for my thumb and the ring finger. Then it has a shaft which has which has ratcheted lock. The shaft is which has a ratcheted lock. Then there is box square lock also. Then coming to the tip, it has a jaw and a tip. Now the tip has it is basically atraumatic. The tip has I think there are serrations, and there is a space also to hold soft tissue structures. And these are opposing. I think the jaws are opposing. And it is used to hold soft tissue structures like fallopian tube during ligation. It could be used during ectopic pregnancy to hold the fallopian tube. Appendix also, we can hold appendix with this. It is made up of stainless steel.
Yes, great. So this is as you described. It has a handle with a lock, a straight shaft, more rounded automatic tip, and there is a Babcock forceps, and it is used for holding delicate tissues such as fallopian tube, ovary, bowel, and appendix. Identify and mention these uses.
So this is Doyne's retractor. It has three parts. One is the handle, the other is the handle, then it is the other is a tip for holding it with the thumb. Then after that there is it is after that there is transverse. It is made into the blade. It is a blade, and the blade is concave, and the tip of it is blunt. This is a heavy instrument made up of stainless steel. It is used to retract bladder during a cesarean section, and it is held like my four fingers will hold the handle, and my thumb will rest on the thumb rest, and I will hold the bladder downward and upward with it. The abdominal wall downward and upward, so as to prevent the bladder from injury.
So is it a handheld or it is a self-retaining retractor?
This is not a self-retaining retractor. It has to be hand-held.
Yeah, and what about the self-retaining retractor, you know?
Yeah, there is a self-retaining retractor also, which is called Balford retractor. It is used for abdominal hysterectomy. That is a heavy retractor.
Great. So this is the Doyne retractor as you described it correctly, and this is the correct way of handling the Doyne. And it's used as a cesarean section for retracting the bladder away from the uterus and girding it against the potential injury. Usually you remove it prior to delivery of the baby and insert it after the delivery to allow good view of the uterine incision. And it is handheld. While the self-retaining one, as you said, it is the Balfour self-retaining retractor. And it's used in laparotomy, and it can be used to explore the abdominal cavity also in bowel section. And as you can see here, the side walls are adjustable. Depending on the size of the abdominal cavity, you will insert it within. So tell me about this instrument and what its uses.
This looks like Zeppelin. This is a Zeppelin forceps. It has a handle to insert my 2 fingers. That is my, sometimes we can insert it my thumb and the ring finger. Then it has a lock, which is a ratcheted lock. It has a shaft. Some of the shaft are straight and some are curved. In one I can see the right angle shaft also. It has box square locks. Then it has a jaw, which will have longitudinal serrations to have a good hold of the tissue structure, and it also prevents the backflow of the blood. It is and then it has a tip.
Not longitudinal. Okay, transverse serration.
Pardon, doctor?
Okay, you can describe it as a longitudinal ridges with corresponding group regarding to the serration you said. Okay.
Serrations are longitudinal and oblique both.
Yes, right. Okay. What is the uses?
And then it has a tip. Tip is tip. It doesn't have teeth, it seems. It is used to hold, have a better grip on the tissue.
What about the tip? Closed or not closed?
It seems to be none of them are open, doctor. I think it should be.
That's great. Yes. So you pick up that you to know what about the jaw and the tip, you need to open the instrument. That's great to know about that. So when you open this, you will find that it is a non-tone. So don't describe the instrument while it is closed. Handle it correctly, open it to describe it. Okay?
Yeah.
So what about the uses?
Yeah, it is used to have a good grip on the tissue because of the serrations and also because of the lock. It is used to clamp the pedicles during hysterectomy. It can be used for infundibulopelvic clamping infundibulopelvic ligament. Can be used to clamp uterine artery pedicle, and also the cardinal and the uterosacral ligament.
Yes.
Is used there.
Yes. So this instrument has a handle, and the handle has a lock and a straight or curved shaft, and sometimes with an angle of 90, the curve. There is a non-tooled jaw, a non-tooled tip, and the jaw has longitudinal ridges with corresponding grooves. So there is double in hysterectomy clamp, and they are used to clamp the vascular pedicle, as you said, the infundibulopelvic and uterine pedicle. What about this? Describe and tell about the uses.
This is Cocker's clamp, and this has a handle to insert my 2 fingers, that is my thumb and the ring finger. Then it has a ratcheted lock. It has a shaft which is straight, long shaft. It has box square locks. Then the jaw has transverse serrations, and the tip is toothed. It is used to hold tough tissue structures, like it is. It is used to hold, like we can use it for round ligament clamping also during to clamp the uterus, not clamp, to hold the uterus during hysterectomy, abdominal hysterectomy, so as to lift it up. That there it could be used. Sometimes it could be used for round ligament clamping, and then it could be used for clamping the cord of the during delivery of the baby. And also it could be used during membrane rupture.
Yes, great.
Artificial rupture.
This has a handle with a lock. It has a straight shaft, full tip, and the jaw with longitudinal ridges and corresponding grooves, crushing jaw. So it's a hemostatic forceps named Coca. It is used to compress arteries and seal small blood vessels. It has a strong rigid teeth which improve compression and grip. It can be used in hysterectomy to clamp pedicle, to be transfixed. It can be used in artificial rupture of membrane and for clamping the umbilical cord of the newborn. So differentiate between those scissors.
Yeah. So there are 3 scissors. One is the Myoma curved scissor. This is a heavy scissor with a blunt edge. With the blunt tip, it is used to cut tough tissue structures like rectus seat, and also during hysterectomy to cut the clamps. Then the other one I can see is Moyniham's Moynihan scissors. It is it has a long shaft, and the tip of it is sharp.
Yes.
It is used for fine dissection, like separating the bladder from the peritoneum, the bladder peritoneum from the uterus during hysterectomy, and also cutting, separating the bladder during cesarean. Also, it could be used.
Can you tell me how are you going to use this type of scissor to dissect through adhesions? Will you use it with a closed blades or open blades?
Pardon, doctor?
When you use this dissecting scissor for dissection, will you introduce it with closed blades
Closed,
or with
always
open
closed.
blades?
Whenever
Yes,
we
yes.
use the scissor, we have to insert it with a closed blade. Even if we are
Yes.
passing the surgeons, we are passing the scissor to the assistant, we have to always close it while we are passing
Yeah,
the
that's
instrument.
great.
And
Yeah, so as
the
you
next
mentioned,
is, the next is the
that's what about
myostraight
it.
scissors.
Yeah. So as you said, yes, the first two pictures for the tissue dissecting scissor, and it used to cut through the scar tissue, and you can identify the tissue dissecting scissors through the curved blades, and it is a heavy instrument. And even the jaw is shorter than in the suture cutting scissor, the Mayo scissor. Mayo is straight and lighter, and the jaw here is longer than in the tissue dissecting scissor. Identify this instrument and mention its uses.
Yeah, this is Myoma Clamp, and
Clamp?
yeah, it is Myoma Clamp, and it is used for clamping the myomas during myomectomy, during when we do it through open procedure, through a laparotomy. And it has a handle, it has a shaft, and it has a tip which works on the principle of spring action. We will insert this myoma screw in the uterus containing the fibroids, and rotate it and fix it, and give a gentle traction so as to remove the fibroid from the uterus during
Yeah,
abdominal myomectomy.
yeah, that's great. So this instrument is named the Myoma Pro. It has a handle, straight shaft, and fox-fold head, and it is named the Myoma Pro, and it uses an open diametry when you can install in a clockwise motion into the fibroid to provide leverage. Thank you, Dr. Shah. We finished about the instrument. Anyone have any question related to this?
No, Dr. Rasa, thank you so much. It was a great learning experience.
Okay, thank you. Okay, so Dr. Fauzia, yes?
Yes, doctor.
Yeah. So this is your talk?
Hello. Yes, doctor, I'm here. Okay.
So Dr. Fauzia is talking?
Yes, I'm talking.
Okay. So this is your task. It's a simulated colleague task assessing the following core clinical skills: patient safety, communication with colleagues, and applied knowledge. You're about to see Mary, an ST2 trainee who has interest in minimal access surgery. You are asked to deliver a task about abdominal insufflation using the Virus needle. You have 10 minutes during which you are expected to explain the characteristics of a safe and effective Virus needle, explain the safety measures before, during, and after insertion of the Virus needle. Take your time, you have 2 minutes, then we will start. Are you ready? Dr.
Yes, doctor,
Fawzia?
I am ready.
Okay.
Yes, I am ready. Hello, I am Dr. Fawzia, one of the registrar with you in the on duty today. Yes, you are.
I am Mary, the ST2.
Okay, Mary. You are in ST2. How is your training going on? Are you
Yeah, everything is
happy
fine.
with your duties?
Yeah, everything
Everybody
is
is
okay.
cooperative with you?
Yes, you are
Okay.
very wonderful.
Today, Mary, today we are here to talk about the varus needle and also about the abdominal insufflation, how we are going to do during minimal access surgery. Is that right?
Yes, right.
Do you want anything? Any more task you want to know today?
No, I just wanted to know about the abdominal insufflation using the venous needle.
Okay, we will start, and in between, if you want to ask anything and you have any query, just stop me and ask me. Okay, Mary?
Yeah, okay, thank you.
Okay, Mary, as you know, this minimal access surgery is the surgery we are doing through the laparoscopy. Okay, for
Mm-hmm.
laparoscopy, before starting anything, we should uh, know about the instruments.
Yeah,
Okay, the instrument and how we have to start the surgery. If first of all, you should see that a patient has given consent. We will check with the name and the medical record number of the patient, NHS number of the patient. We will check on the consent. After that, we have to check our WHO checklist that everything is patient know about which surgery she is going on, diagnostic or therapeutic, and she knows all the pros and cons. And also, we should know that that anesthetic is available and the scrub nurse and all the instruments are there. Okay.
okay,
Okay, about this, as you know, that we have to start our surgery with this one. We will start our surgery with this. First of all, we have to insert this varus needle before starting our laparoscopic surgery for diagnostic or therapeutic purpose. Usually, we are using it through the belly button. But if there is a previous history of midline surgeries and midline abdominal surgeries, or there is risk of adhesions, we can use the open technique or the palmas technique, which I will let you know. Okay. Usually,
okay,
we are giving this a small incision, a small vertical incision in the base of the belly button, and then we will insert this needle at
mm-hmm.
we will we will insert this needle at 45 degree, and we will usually heard two clicks. We will feel two clicks, one at the level of the rectus and one at the level of the peritoneum. After that, we should not move it from we should not move it here and there just to check that we are in peritoneal cavity, because we can injure the other visceras. We have to do the Palmer's test. Do you know anything about Palmer's test?
I don't have any idea about the venous needle at all.
Okay. So Palmer's test is there that we inject through through a syringe. We will attach it to the varus needle, and we will pass few drops of normal saline, and then we will push it again. If it comes with the it comes back, or it comes with the uterine with the intestinal contents, then we are in the closed, we are not in the open peritoneal cavity. Maybe we are in the bowel, or in between the abdominal wall layers. Are you getting my point? And if it does not came, normal saline doesn't came, this means that we are safe in the peritoneal cavity.
Okay.
Then this varus needle has two parts. There there is a mm, there is a there is a cord-like structure which we attach with the carbon dioxide insufflator, through which the carbon dioxide will go inside, and we have to keep the pressure before insertion of the primary trocar about 20 to 25 millimeter of mercury.
Sorry, so
You are getting my point?
When I insert the virus needle, what is the supposed pressure to be to make sure that I am within the peritoneal cavity?
Pressure should be at least 8 millimeter of mercury, but we have to increase it for primary trocar. We have to increase it up to the 20 to 25 before inserting the telescope. After that, we have
so how can I hold the needle?
You will hold the needle between the thumb and the index finger, and you will.
At what angle can I?
At 45-degree angle.
45. Okay.
After insertion, you will feel two clicks. What clicks you will feel? I told you before. One for the rectus sheath and one for the peritoneum.
Okay. Okay, still you have 2 minutes. What other point you'd like to add? Complete.
Yes, I want to tell you about this open technique and this one.
I don't want to know about open technique.
Palmer's
I just
entry
want
technique.
to know the characteristics of a safe and effective virus needle. What safety measures to be done before, during, and after the insertion? What are the safety points related to it before, during, and after? That's what I'd like to know about.
Doctor, I didn't read it because I was on duty. I just read.
So close the task.
Yes, doctor.
How are you going to close it?
By J-shaped needle, we have to close. If
in generally, how are you going to close a teaching session? Even if you don't know about the topic, try to collect the mark of communication and the point which are steady in every teaching station, how to close it. Important point you need to know about the teaching in the end, what to do.
Yes, Mary, sir, I will tell you later on, and we will have better next session in near future. I will give you some RCOG videos and RCG material for you to read about this laparoscopy and about the safety measures used during the varus needle insertion. I think I hope that it will be helpful for you.
Okay. Okay, Dr. Jose, thank you for your trial. It's really very nice for you to try that you don't have knowledge about it or don't revise it recently. But if this unfortunately happens in the exam, try still to be confident and try to gain mark from other points, as in your introduction and confirming the aim of meeting as you did. Try the time is still finished by now. Try to follow the teaching module as we described before. When you introduce yourself without doctor. Say, I am Fawzia, not doctor. And also, you need to ask about the background knowledge of the candidate in front of you. What you already know about Vera's needle. You will gain mark for this question. You need to ask why I wanted to know about the Vera's needle. You need at the end of the session to ask me about my feedback and the plan for future learning. Those tasks or those points will help to give you some mark that if added to another station, you will couple the lost mark in this station. So even if you don't know about the topic, try to collect mark from it. And if the role player asks you questions that you don't know, don't try to imagine the answer. Just tell, it's not up to my knowledge right now. I will ask my consultant and review the literature and have another appointment with you. Okay, Dr. Fawzia?
Okay. Thank you, doctor.
Thank you for the trial. And also, just I'd like to correct only one mistake you did regarding to the knowledge. The angle of the insertion of the Vera's needle, it's perpendicular to the skin. It's a 90-degree angle. 45 degrees is for the secondary trocar, not for the Vera's needle. Remember this point. Thanks again for your sharing, Dr. Fawzia.
Okay, doctor.
So let's talk about this task. I will talk mainly about applied knowledge because we discussed before about how to follow the teaching station. In the applied knowledge here, you need to first handle the Vera's needle and illustrate to the role player what it is formed of. So the Vera's needle has an outer cutting sheath and the inner spring-loaded and gas-transmitting safety sheath. And to be an effective Vera's needle, better to be single-use device, so it will be less liable to technical failure because if it is reusable, the sharp outer part will become with time less sharp. So this makes it technically difficult to insert it through the umbilicus. So this is the point of being a single use, and also the benefit of avoid contamination issue associated with reusable instruments. And the point should be sharp, and the spring should be functioning properly, and the gas tubing should be connected, and the installation convince and gas flow rate noted. You need to make sure that there is no resistance to flow of carbon dioxide. Again, I hold the Vera's needle, I will demonstrate its part to the candidate. Then, in the task it is written, you need to tell the candidate about important point before. So before you need to check your instrument, you need to check that this Vera's needle is working good. How to check that? First, you need to check the spring function. As you can see in this picture, this is the spring function. When you touch the skin with the Vera's needle, the first part will be the blunt end. And with further pushing on the Vera's needle, the sharp part will start to penetrate through the skin. And the benefit of this, if unfortunately you go through a towel, it will be put away from your field by the first part which you come in contact, which is the blunt. The sharp part will come later on. This is the spring mechanism. As you can see in the picture, it's really, really good illustrated in this picture, the spring mechanism. The issue is that you need to make sure that the gas flow without resistance within the Vera's needle before using it. Simply attach it to the insufflator, open the valve, and make sure there is no resistance. So by this way, I'm confident that this Vera's needle doesn't have any issue. After that, a much needle length is required to transfer the thickness of the abdominal needle, the abdominal wall. And to be inserted, even if your woman or your patient is obese, you need to grasp the Vera's needle 3 to 5 centimeters from its tip. And this is another important point. As you can see in the picture on the left side, here the surgeon grasping the needle from the upper part, but this is not correct. You need to grasp it 3 to 5 centimeters from the tip. So you will be good against further penetration with the virus needle. So this is another important point for effective virus needle insertion. The other issue that when you apply the virus needle, you will hear and feel double click sound. As you said, Dr. Fawzia, the first is the rectus sheath and the second is the peritoneum. After doing that, the needle should not, another point of safety here, that when you introduce the virus needle, it shouldn't be connected to the gas during insertion. So before insertion, you connect it to the insufflator to make sure that there is free flow of carbon dioxide. After making sure that it flows without resistance, close it and enters the virus needle without being connected to the gas insufflator to avoid the risk of carbon dioxide in collision. Once you are happy with the placement, you need to do certain points or certain tests to make sure that you are correctly place it within the intraperitoneal space. Point of safety that you mentioned, Dr. Fawzia, that we don't need to move it all around or laterally to avoid any injury to the bowel. But how to confirm that it is in a correct place? Several tests like Palmer test, hanging drop test, and measurement of the intraperitoneal pressure. How to do this test? Simply, you will connect the virus needle with a syringe. Try first to aspirate. If it is correctly placed the intraperitoneal, nothing will come. But if when you do aspiration, you aspirate fluid or blood or bowel content, it indicates that it is not correctly placed. After that, you will drop a few drops of saline within the syringe. And you will notice that it will be sucked within the negative intraperitoneal pressure. So this is another indicator that I am correctly placed the virus needle intraperitoneal. After doing that, you will connect the virus needle with the insufflator to measure the pressure. And if it is intraperitoneal, the pressure should be less than 8. Not, Dr. Fawzia, as you said, at least 8. No, it needs to be less than 8. Less than or equal to 8 millimeter mercury. So, point to be remembered during the virus needle. It needs to be sharp with good and tested spring action. The operating table while you insert the virus needle needs to be horizontal at the start, not entering the ring position. The patient first lie in horizontal position to avoid injury to any visits. The lower abdominal wall also should be stabilized, so the virus needle can be inserted at a right angle. It is handled like a pencil and inserted at a right angle, in an angle 90 degrees, not 45. Remember the double click sound, and remember the point of safety that you need to avoid lateral movement of the needle, because this can convert the small needle point injury into the wall of the bowel into a large or compound tip. So I'd like now to talk about laparoscopy in general. Then we will discuss again about any difficult point in this station. So from the start, when you enter the theater, you can find the laparoscopy equipment in the form of here the printer at the bottom. Then the second two are the light sources, and this is the storage device, and this is the screen which can you see on it the insufflation pressure. And here on the left side is the carbon dioxide cylinder. So here is the equipment of the laparoscopy. Again, this is the printer, the light sources, storage device, insufflation screen, and this is the carbon dioxide cylinder. After that, you will find on the scrub table the following instruments. As you can see, we have here Sims speculum, we have a single tooth tenaculum, we have Wolzellum, we have this instrument which is characteristic to the laparoscopy. It is named speculum uterine manipulator. Speculum uterine manipulator. And look, in this instrument, you can find that there is a screw. What is the importance of this screw? The importance is that, look on this second picture, you can find that when I apply the Wolzellum to the cervix and then applying the uterine manipulator, I can fix the Wolzellum to the uterine manipulator and tighten the screw. So I can use the full grip to move the uterus during the laparoscopy. Okay? After that, you can find another scrub table which contains the laparoscopic instruments. As you can see here, we have, this is the laparoscopy, and we have different light sources. We have here the gas insufflation device. Here is the virus needle, and here we have different sizes of the trockers. So, what to do pre-operative? In the task, you are asked to tell the candidate what important points is 50 before using the virus needle. So the important point is that starting from history and the examination, I need to take a history, examine the patient to make sure that there are no risk factors like high or low BMI, any history of previous surgery, inflammatory bowel disease or pelvic inflammatory disease. So I can categorize if the patient is low risk or high risk for injury. I need to review the consent. I need to do WHO surgical checklist. I need to check my equipment, check the light source, attach the camera and check the light balance, check the virus needle, as we said, check the spring mechanism, make sure that the line is patent, make sure that the gas flow without resistance within the virus needle, make sure that the diathermy pads are correctly applied to the patient, make sure that the carbon dioxide tank is not empty, and remember that one of the associated procedures or operations that can occur with laparoscopy is a laparotomy. So you need to have facility for laparotomy in case of you need. So those are the points of safety before application of the virus needle. History examination, WHO checklist, use the consent, check the light source, the camera and the virus needle, and the carbon dioxide tank, proper application of the diathermy plate, and facility for laparotomy. Going to how you are going to perform the laparoscopy. So first, the abdomen, the vulva, and the vagina are cleaned with aqueous betadine. And as you can see in this image, the initial position of the patient is a horizontal supine position, while the hip is slightly flexed. Remember, the other position, Leo Davis position, this will be after application of the laparoscopy and the trocar. But in the start, the initial position of the patient is a horizontal supine position with the hip slightly flexed. After doing cleaning and proper position of the patient, you need to castrate the bladder so that inadvertent bladder trauma during virus needle or trocar insertion is minimized. So all of those steps are prior to virus needle. Clean and wrap, castrate the bladder, the position of the patient. Then you need to apply the thin speculum as in this image. Apply the thin speculum in the vagina, and the anterior lip of the cervix will be grasped with the bullellum. Then apply the sound to measure the length and the direction of the uterus. After that, you will apply the uterine manipulator, and the bullellum is secured to the manipulator by tightening the screw, as you can see here in this picture. He is trying to tighten the screw after connecting the bullellum to the uterine manipulator. After doing that, palpate the abdomen to check the position of the aorta or any masses. After doing this, so just to revise this point again before attaching the virus needle to the patient. First, review the consent, history examination, make sure that all of your equipment are working correctly, make sure that the virus needle, there is no any issue with it, castrate the bladder, clean and wrap, application of the uterine manipulator, and after that, you will start the application of the virus needle. How to do this? An incision here is needed in the base of the umbilicus. Why in the base? Because it is the thinnest part, and here it is the muscle, and here the brain is firmly attached to the abdominal wall. Then the incision, when you do the incision, you need to tell the candidate you need not to do it too large, because if it is large, you will not be able to create the efficient pneumoperitoneum. The gas will escape. So I will do small incision at the base of the umbilicus, and not to be large to avoid difficulty in generation of the sufficient pneumoperitoneum. Then the virus needle is introduced firmly in the umbilical incision at 90 degrees, while holding it as a pin to allow controlled entry. At this time, you can hear and feel two click sounds. The first is the rectus sheath, the second is the peritoneum. I'd like to ask you one question. What about this image on the left side? Is it correct placement of the virus needle or not? I would like some of you to tell me. If the surgeon here holding it correctly?
No.
Can you? Yes, no.
it should be in the pen holding fashion, that is below, between, and also I think we should lift the abdominal wall.
What else? Another point which I discussed in the first.
Also, ma'am, it is
3 centimeter distance.
Yes, yes, that's
from
great.
from the
Yeah. Yeah. So you need to handle the virus needle 3 to 5 centimeters from the tip, so you can control its entry, avoid its further penetration, which could lead to damage of the intra-abdominal. So the virus needle need to be handled like a pin at a 90 degree and within 3 to 5 centimeters from the tip. Okay, what else? What after doing that? I need to confirm that this virus needle is correctly placed within the peritoneal cavity. So what I am going to do, first I will aspirate. When I aspirate, no fluid or blood will come. Then I will apply few drops of saline through the virus needle. If it is correctly placed, I will see that these drops have stuck within the negative intraperitoneal pressure. So this tell me that there is a correct intraperitoneal replacement of the virus needle. Another important point of safety you missed during this task to tell the candidate after two failure tests, you need to stop and seek advice from the consultant. You can try only with 2 attempts. After 2, seek advice. The most predictive test also to confirm that you are correctly within the intraperitoneal space is named the pressure flowmetry test. How you are going to do that? As you can see in this image, here the virus needle connected to the carbon dioxide insufflator, then look on the screen, make sure that the pressure is less than 8. If you are happy with this placement, start your pneumoperitoneum. Do the initial insufflation. And the initial insufflation pressure here needs to be set not higher than 25 millimeters mercury. So remember, we have 2 pressure. The first one less than 8, which indicate correct intraperitoneal replacement of the virus needle. The second one is the initial insufflation, which is 25. Later on, I will talk about the last insufflation pressure, which after application of the virus needle and the trocar, you will lower the pressure to be between 12 to 15. So again, don't mistake between the pressures. The first one less than 8 to indicate correct intraperitoneal replacement of the virus needle. The second one is 25, which is the initial insufflation pressure. The last one is between 12 to 15, and this is after placement of the after that. After doing the initial pneumoperitoneum, I need to know the sufficient. And you can notice that the liver damage is not there. Then, after doing this, remove the virus needle, justly enlarge the umbilical, you are able to introduce the probe. And generally, as long as you are going to use an instrument, check this instrument. Make sure the trocar move freely within its cheese, as in this image. He is moving the trocar within the cheese. It moved freely. So, how to introduce the primary trocar? Using my non-dominant hand, as here in this image. The non-dominant hand used to generate more pneumoperitoneum, so it will be less likely for the trocar to enter the bowel or the aorta. The trocar will be inserted 45 degrees. So what is it is for the primary trocar. But remember, it is for the virus needle. 45 is the virus needle, and also the secondary trocar are 90 degrees. So I will and insert it with a degree 45 to the skin aiming towards the pelvis. After doing this, I will remove the trocar and introduce. After introducing the laparoscopy, important point is safety to 60 degree view by rotating the laparoscopy to make sure that there is no any bowel injury. This is another point of safety. Obtain 30-60 degree to make sure there is no bowel injury. After doing that, you can now do your laparoscopy. If it is only diagnostic, you will not need to introduce another trocar. Just you can look on the screen and see manipulating the uterus by the and see if there is any. But if you are going to do any maneuver, you need to introduce secondary force. How are you going to need to be lateral to the inferior digastric distance. You can see here, this one, which I use as the arm, this is the inferior epigastric. You can look on the screen and see the point of entry of the secondary force to be lateral to the inferior epigastric vessel. Roughly taking that, usually produces as in this image in a line joining the umbilicus to the anterior superior iliac spine at the junction of the medial 2/3 and lateral 1/3. So I will select this point between the lateral 1/3 and medial 2/3 spine while looking on the screen to make sure that the point of entry here is lateral to the inferior gastric vessels. Notice that while I'm using the trocar, you use the index finger to guard the trocar. So your index will help also to avoid further penetration. As we did before the virus needle, the distance 3-5, here in the trocar, guide it with your index, so you will not penetrate deeply. After doing that, remember also that the report is inserted perpendicular at a degree 90 degrees. So again, we have 45 degrees for the primary trocar, but for the virus needle and the secondary trocar, we have we have a 90 degree. After application of the port, the first port you can apply the other port if you need, and you will inflate the balloon to avoid dislodgement of this trocar. After doing that, once all trocars are inserted, as in this image, you need to lower the intra-abdominal pressure to be between 12 to 15 millimeters mercury, so that you will decrease the risk of embolism, reduce the risk of vena cava compression, as well as allowing for easy ventilation of the lung. Following this, now you will change the position of the patient. First, start with the patient lying horizontal. Now I will change the position to be Lloyd-Dietz position, which means that the patient will lie with the head raised 20 degrees and the patient tilts at 30 degrees. Why? To allow the small bowel to fall away to do this. So I will to after finishing your laparoscopy, how to remove deflate the balloon before the removal. Remove the trocar under direct laparoscopic vision, and then remove the laparoscopy and primary trocar. It's important to expel as much possible gases from the peritoneal cavity to avoid uncomfortable sensation of the patient. Then you can close the applied incision using reed, and the rectal sheath to be closed using the J-shaped needle to avoid the risk of herniation. I finished now talking about the laparoscopy. If anyone have any question related to this topic, please tell me. Hopefully it's clear now. Okay. Okay. Another point that I'd like to add also is technique and point technique. The technique meaning is that you will do the incision in the intra-umbilical skin. Okay. And you will do the incision with the scalpel, open the subcuticular fat, and then the rectal sheath. Then it is elevated using the tissue forceps, as in this image. And then the peritoneum is inside under direct vision to be elevated and make sure that there is no underlying bowel. This is the open technique. You don't lose in the open technique the virus needed. Just to open small incision for the laparoscopy using an open technique. Open through the skin, subcuticular, the sheath, hold the peritoneum, make sure that there is no bowel underlying it. The other point of entry is the palmar point of entry, which is the area of the left hypochondrium in the mid-clavicular line, just below the costal margin. And this point is the least point of adhesion, but make sure that the patient don't have splenomegaly or full stomach before applying the virus in this point. So does it make sense, this presentation? Anyone would like to ask anything about the laparoscopy? Is it clear?
Hello, ma. Hello, ma.
Yeah, hello?
Yeah, in the past, they used to say that before you insert your varus needle, you need to hold the anterior abdominal wall up before the insertion. Is it still the same?
I'm sorry, I can't get your question. Can you repeat it, please?
Okay, what I'm saying is that in the past, they said before you insert your varus needle, you need to hold anterior abdominal wall up. You raise it up before the insertion. Is it still the same? Because you didn't mention that when you are inserting your varus needle.
Unfortunately, I can't get your question. Can anyone help me with your question? Sorry, I can't get your question.
No, my question is that, do we still hold the anterior abdominal wall up during insertion of varus needle?
Oh, yeah, I get your point. Yes, yes. You mean that before inserting it, you can hold the abdominal wall. Yeah, some surgeons do this.
Okay.
Thanks for this point. Okay. Any other question, dear?
Dr. Rasha, please, in the open technique or Hasson technique, it is done after it is done after varus needle insufflation with the carbon dioxide, ma'am?
No, it's the open technique. It is instead of using the varus needle. You will not use a varus needle in the open. You will avoid the varus needle
I
because
mean, how you will insufflate the abdomen?
Sorry?
How we will insufflate to distend the abdomen, ma'am?
Okay, yeah, you will open through the open technique, then insufflate after that. You can insufflate now with the varus needle, but don't use the varus needle from the start. Just to open the point of entry, then introduce it under direct vision. You see, open and see.
Yes, ma'am. I think the opening will be wide. If it will capture the CO2 inside the abdomen. How?
No, don't be wide. It's only small incision to allow open entry for the varus needle to do the insufflation. The point of the open technique is that you can see with your eyes that there is no adhesion.
Yes, ma'am, but it is not wide. It will not lead to escape of the CO2.
No, not wide. And even some surgery can do the insufflation through the trocar itself.
Okay, ma'am. Okay, thank you.
Thank you for your question. Any other questions?
Excuse me, Dr. Rasha, this lifting of the abdominal wall may result in the failure of the entry of the varus needle. Abdominal wall must be stabilized, what I remember in the guideline.
Yes, you can add this. You can add this point. Yes. But if you follow even the main points of doing it correctly, yeah, you can. Yeah, you can do it even without holding. But instead, you can add this point. It's correct.
Okay, thank you.
You're welcome. Any more questions?
Dr. Rasa, but still I have confusion because when we are doing the varus needle technique, we have to lift the abdomen.
Okay, add this point. No problem. Add this point. If you'd like to add this point. But the main point is we described before is to follow this main point, and then you can add this point when you introduce the varus needle. No problem. Add this point.
So in exam, what we should say, like in the guideline, it is written that the abdomen should be flat.
Yes, should be flat. Yes, the first position, the patient will be horizontal position. Then after introducing the varus needle, the trocar, the laparoscopy, and you need now to do your laparoscopy, change the position to be Leo David. But first, it's the horizontal supine position.
Actually, ma'am, this is a more precaution which is introduced by other surgeons. But the basic is it is flat and we insert perpendicular the varus needle, and that's why it has the spring action in order to retract. But it is invented, this elevation of the anterior abdominal wall by surgeons, that is for more and more precautions.
Yes,
Especially
yes, that's what I mean, Dr. Ansar. Yes, this is for more precautions. Yes, you are right. But still, you can add. It is not correct. It's correct. You can add it.
Yes,
So we
ma'am.
have to speak for the guideline that we will stabilize the abdomen and insert the varus needle. We will not lift the abdomen. That is what we have to say.
Actually, they don't allow lifting abdomen because the intestines may come up with the fold of the skin.
But we
and-
lift the abdomen because it protects
This
the.
point is not mandatory. This point is not mandatory. If you miss it, you don't list mark for that. At least if you follow the points which I mentioned before, you will get the most mark for this station. It is not mandatory. Some surgeons don't do this. If it is clear and I can introduce the varus needle, I will not go to hold the abdominal wall. It's not a point of safety here. It is not mandatory. You can do it without elevating the abdominal wall if you follow the other points which I mentioned. But if you need to add it, it's okay, no problem. Add it.
Yeah,
Okay?
thanks for clearing me. My doubt is clear. Thank you, doctor.
You are welcome. Any more questions? Okay, let's move to the other station. Dr. Somia. Dr. Hasina Akhtar. Okay, anyone would like to do this last station?
Can I try, ma'am?
Yes, Dr. Ansar. Okay.
Thank you, ma'am.
So this is your task, and now you have 2 minutes to read it. It's also related to the laparoscopy, but it's a role player task.
Dr. Rasha? Dr. Rasha?
Yes?
Hello? There is
Yes?
too much noise from Intisar's side. There is too much noise of traffic, I think.
Try to be in a quiet place, Dr. Intisar, to make your voice clear. Okay?
Me, ma'am. I have a noise. I'm in a closed room, ma'am.
Okay, no problem. Okay. I just would like you to add in this task, there is a point of information gathering. I forget to add this point. So there is information gathering in this task. Okay?
Okay, ma'am. I'm sorry if I cause any upset for any one of my colleagues. Sorry.
No, any update, Dr. Sorry, you're welcome.
Okay, start, ma'am. Or
Okay,
there is
let's
still
start.
time.
Your 2 minutes is finished. Are you ready to start now?
Yes, ma'am.
Okay.
Hello. I am Intisar Abdul Qadir, one of the doctors in the pre-operative clinic. May I confirm your name and age, please?
My name is Sally Smith. I'm 38.
How do you like to be called?
Sally is fine.
Sarah. Hello, Sarah. Nice to meet you today.
Sally is fine. Sally.
I understand, Sarah, that you are coming today to discuss your operation, which you have booking for, which about the removal of an ovarian cyst, a left ovarian cyst of yours. Isn't it?
Yes, that's right.
Okay. Before proceeding into talking about the procedure and explaining to you its risk and benefit, can I ask you a couple of questions?
Yeah, sure.
Okay, Sarah. Do you have any medical condition, Sarah, that you receive any treatment for?
Yes, as you can see from my notes, I have Crohn's disease and I did for laparotomy for bowel resection.
Do you receive any drugs for?
No.
And the condition now is settled down?
Yeah.
And you are regularly follow up with your specialist doctor?
Yes, yes.
Do you have undergone any surgery before, apart from that bowel resection?
I have 2 cesarean sections before.
Yeah. Okay, and they were uneventful?
Yeah.
Also, this surgery for bowel resection, I understand from your notes it's a midline. It's you have done a midline incision in your tummy.
Yeah, you know, doctor, it's an ugly scar in my tummy, and I'm really worried that the keyhole surgery will end in another one.
Okay, don't worry about that. We will try our best in order not to be not for the keyhole surgery to be more disfiguring for you. But okay, about that laparotomy, it was like dissections. It was an uneventful and everything going or passed uneventfully and successfully after surgery.
Yes.
Since how long that surgery was?
It was about 6 years ago.
Yeah, and you are in good condition now?
Yeah, I'm fine.
Okay. Do you receive blood transfusion before?
Yeah, I don't have any objection for that.
Okay. Are you allergic towards anything or any drug?
Yeah, I'm allergic to penicillin.
Could you tell me more about the allergy, how it manifests?
Yeah, once I take this severe rashes all over my body and even difficulty breathing occur. That's why they told me I don't need to take it anymore.
Okay, thank you. Tell me about that, and definitely we will put this in your notes. Okay.
Thank you.
Sure. Do you smoke, Sarah?
No.
Do you drink alcohol?
No.
I'm sorry. Do you take any recreational drugs or street drugs?
No, doctor.
Okay. Are you updated with your cervical screening?
Yes, the last one is 1 year ago and it's normal.
Do you use any contraception now?
Yeah, I'm using barrier method.
Yeah, and the periods are regular?
Yeah.
When was your last period, please?
1 week ago.
Okay. Do you remember what type of anesthesia you received, whether in the section or in the laparoscopy? Or the keyhole surgery?
It was general anesthesia. I put to sleep.
Yeah, and nothing will happen after general anesthesia. You withstand it well. Yeah. Okay. Do you have got any before any history, any past history of blood clotting, leg swelling, especially
No.
after surgery?
No,
Okay.
no.
Any family history of blood clotting or pulmonary embolism or
No.
blood clotting in the legs?
No.
Okay. Okay. Any past history? I'm sorry, if in the in your family of any diseases like hypertension, diabetes, any ovarian diseases before, any cancer before? I'm sorry to ask that.
No.
Okay. Thank you for sharing those information with me. And if you allow me, I want to examine you in the front of the chaplain to measure your blood pressure, specifically your blood pressure. Is that okay with you?
Yeah.
And
Okay.
I'm sorry, I will try to examine your abdomen to feel your abdomen if there is any pain, any mass felt. All right?
Okay.
And of course, we will do certain blood tests before surgery, before the keyhole surgery, to be sure that all your systems are working well. Okay? Coming to your concern now, what we understand from the ultrasound that there is a 6 centimeter ovarian cyst. Most likely, we call it a dermoid cyst, which is actually it's a benign cyst. And after consultation with your consultant, you are free about performing
the operation. I know well about this dermoid cyst, but I'd like now to know more about the risk of the operation.
Okay. I think you know about your BMI, Sarah, and you know that you are above the average weight.
Yeah, I know.
And I'm sorry to tell you, this overweight add to your risk during any surgery, whether keyhole surgery or an open surgery. So that we have to ensure that your blood pressure is well, as I told you, and other investigation. Also, we have to do what we call a VTE assessment for your condition. That is to say, we will assess you whether you are going to need any blood thinning agents before the operation and after the operation. Also, we will advise you to wear certain anti-thrombotic stockings just before the operation and during the operation. Okay, and as I told you, to know whether you will know a blood thinning agent or not. But I think according to your age and your BMI, you will need a blood thinning agent after the operation for at least 10 days. Okay?
Okay.
Then coming to the previous surgery you have undergone in your abdomen. Actually, this will increase the liability of injury once we try to enter your abdominal cavity through the keyhole surgery, because there is a lot of adhesions inside your tummy, especially in the midline. Also, because of the bowel resection, there will be inside your tummy or inside the cavity of your tummy a lot of adhesions suspected. So there is a great liability to injure any of the inside organs or blood vessel or bowel upon entry. So in order to try to avoid this, we will try to enter from another safer place, which we call it the palmar point. This palmar point, actually, it lies just below your left costal margin, just about 2 to 3 centimeters in the middle line, because it is proved by the statistically, this is the least point where we could find adhesions in the whole tummy. So in order to avoid the midline, we will suspect there is a lot of adhesion there. We will try to enter through the palmar point and to go on with the surgery and try to remove the dermoid cyst trying to remove that cyst totally and intact. Because there is a possibility that this dermoid cyst could be ruptured inside your tummy, specifically when there is difficult entry from the adhesions. And actually, we try to avoid this. Yeah, because the material contained in the dermoid cyst is really very irritant. Yes, ma'am?
The 10 minutes have already been finished.
I'm sorry, ma'am. Sorry.
No problem.
This is also my problem.
Yeah, I know.
Want to
yeah, it's difficult. I know.
Yeah, I want to tell her, I want to tell the patient that we will try to remove the cyst intact to avoid the spillage of its content, which is very irritant to the peritoneal cavity, can lead to very severe adhesions. And also we try, there is a live.
Dr. Saad, here in the task, it's written that you are aiming to tell the patient about the risk and benefit of the procedure she's going to do. So your main task is you're going to take a consent. So why you didn't follow the approach of taking the consent? Tell her about the benefits, the risk, and what additional procedures that can be done. You talk about the anesthesia, and then by the end you need to ask her, are you happy to proceed with this operation? So this is need to be followed because it is the main point of to take mark from this task, to take the consent from this patient. I know that you have good knowledge about
I take a long time in the history. Yeah.
Yes. I'd like you to know. You know about all the points. I know that you have a good knowledge about this, but you only have about start the counseling and still only 2 minutes remaining in the task.
Okay, I will make a resume very rapidly that I will tell her the very common side effects of the surgery and the dangerous side effects and the benefit, of course, of especially of entering through the palmar point to avoid the adhesions and try to remove this totally intact because this is liable to torsion and liable to many complications. And also to analyze it histologically or to analyze the tissue to ensure that it is a benign cyst. Okay, ma'am. And she is liable to hemorrhage, she is liable to injury of bowel, she is liable to infection. And but by the using of the palmar point, we try to reduce the incidence of this. About the most common risk is of course the bruises in the abdomen, slight discomfort, but the benefit of the keyhole surgery, the short stay in the hospital, the rapid return to work, and of course low cost, or the cost is lower than the abdomen, and of course what she's really concerned about, which is the disfiguring of her abdomen. We try to avoid this again, and we could do. If we can do, we could remove the scar, the ugly scar tissue, if she has a collide or ugly scar, also during the keyhole surgery.
Yeah, that's a great, Dr. Saad. But try to practice this again with your study partner so you can finish it within the 10 minutes. But you have a very good knowledge about this task. And
thank you, ma'am.
Well.
I am good, ma'am.
Yeah, you are welcome. So you did it well by doing from the start. You do a very well introduction, and you set the aim of your consultation. And a very nice question that you ask the role player if she has any objection from blood transfusion. And it's a really important question to ask any role player who is coming or plan to have a surgery. Ask, do you have any concern about blood transfusion? And also, in any patient who is about to have a surgery, don't forget to ask about the last menstrual period and the contraception to make sure that she's not pregnant. You did it very well also by asking about the allergy, what happened, and I will document. And also, you ask specific questions about the past and the family history. No, don't only give her what is family history concern. You ask about any history of cancer, ovary, any history of clots. And you explain well about the palmar point, but it's better to draw it. Instead of telling her left post margin and statistically this adhesion, just in hurry, draw the abdomen, and then this, here's the point of entry, we name it palmar point. Just draw it. And
yes, ma'am. Okay, this is a nice idea.
Yeah, thank you. So other also point I'd like you to do is if there is point of history written in the task, don't waste your time and ask it again. You can find in the task that this patient had Crohn's and she underwent a laparotomy and she had a dermoid. So confirm this data only. I can see from your notes that you have you underwent an operation, midline laparotomy for Crohn's disease. You did a bowel resection. Is that correct? So confirm instead of asking her. It will avoid wasting your time, and even you will be more confident because the role player may told you you have my notes in front of you and it is written. You didn't go through my notes, so confirm what is mentioned in the task. Don't ask it again. Okay? And
Okay,
also
ma'am.
from the start, try before start counseling your patient and asking questions. Try to know from the start what is her main concern. Tell her what is your expectation for our session or from our meeting today. So she will tell you that, yeah, I wanted to know about the risks of the laparoscopy and if there is possibility that I will have another ugly scar on my tummy. So this is the main expectation, this is her main concern. And you need before finishing the task to answer this concern. And try to follow the aim of the consultation. Don't go through the details of the dermoid cyst. It is not a task of talking here about the cyst. It is a task of taking consent. Okay, but you did it very well and you have a good knowledge, but try to repeat it again with a study partner so you can do it next time in time. Okay?
Okay, ma'am. Thank you for this opportunity, ma'am. Thank you very much.
Thank you. You're welcome. So, what important point in this task? So, as Dr. Saad did a good introduction and confirming the aim of the consultation, I understand that you are here today because you are about to sign the consent for laparoscopic surgery. Is that correct? So, I confirm the aim of the consultation. Ask the main concern of the patient and obtain a relevant gynae history as she did. She asked about her period, when was the last period, what method of contraception. Also, important point to ask in any patient coming before a surgery about support at home. Who will take care of her after the surgery? Especially this patient may end in laparotomy. Again, there is a risk that she has laparotomy. To ask about support at home. If there is someone who is here will take care of her after the operation or not. So social history here is important. And as Dr. Saad did, ask about injection for blood transfusion. Then you need to discuss about different options of entry through the abdomen. You can tell her about the closed entry of the virus needle, but it is risky because you have scar tissue within your tummy. Another method which is named open Hasson and describe it for her. And the other point of entry which is Palmer point by drawing this. Simply draw and tell her we can enter from your tummy bottom through the needle, but it is risky, so we can use an open technique or go to this point in the draw. This is named Palmer point. Then you need to explain here that for most of women like yours will have a good outcome of the laparoscopy, but there is a risk because you have previous surgery. So there is a scar tissue in your tummy, and this makes your operation more tricky. Then go through the complications and tell her that on your side, this risk may be slightly higher than normal. And then, usually, if it is a consent in the exam, you will have the paper of the consent. And you need to follow this. How to follow this? You need first to confirm the name of the surgeon. You are here to have, because you are about to have a laparoscopic removal of the dermoid cyst. Then explain to her the benefit. We are going to do this minimal access or this keyhole surgery to remove the cyst, so you will get rid of from your symptoms of the abdominal pain and whatever symptoms she has. So there is the benefit. Then go through the risk. And here is the risk. You can classify it into serious risk and frequent risk. The serious risk, as you said, there is a risk of injury to the internal organs, which is about 2 in 1,000. But here in your case, because you have a scar tissue within your tummy, I'm afraid that it is slightly higher than normal. And even if this injury occurs, there is a risk that we may have another operation in order to repair this injury. Then don't forget that there is a risk of failure to gain entry into your tummy. And even we are not able to do the procedure. We cannot enter your tummy, so it could be through a laparotomy or an open technique through a laparotomy, okay? And don't forget to tell her about the risk of hernia, especially this woman has a BMI of 40 and thromboembolic complication. As you said, we will assess your risk of clot, and I will involve my consultant and I will involve the blood specialist to see if you are about to take blood thinning medication or not. Don't tell here that I think, don't I think. We will assess your risk with the input of my consultant and the blood specialist. They will see and determine if you need to take blood thinning medication or not. And don't forget to tell any patient who is about to have operation about the risk of death. And I'd like to ask you, Dr. Saad, how are you going to tell her about the death? How you counsel her about this risk?
I will tell her, ma'am, the honesty demand me to tell you that there is a very rare risk of occurrence of death during laparoscopy, which is about 3 in 100,000. But I'm sorry to tell you that don't want you to be afraid. It's very rare risk, but I have to tell you.
Yes, you are right. So I'm going to tell her that although there is a very rare risk of death which can occur in this operation, but you need to know about that risk. It's a very rare. It's only about 3 to 8 out of 100,000 women. So I will just reassure her it's rare, very rare, but you need to know about this risk. Don't mention it in hurry, because some candidates say there is a risk for this, which is 3 to 8. Don't in this manner. Reassure her it's very rare, but you need to know about that. Then go through the frequent risk, which is closing, fluid discoloration at the site of the entry. You may have a shoulder pain, you may have gapping of your wound, and there is a risk of infection. Do not forget in the task of consent to tell about extra procedure that may occur. Especially this woman is concerned about the risk of having another scar, and you tell her, don't worry, this will not happen, we will take care of you, but this is not the answer. You tell her, we will try our best to avoid this operation again, but still there is a risk. There is a risk of extra procedure that can occur, and even this can lead to another laparotomy. But we will try our best to avoid that, but still there is a risk. Because if you don't tell her about this after the operation, if you need to take a laparotomy, she will have a complaint against you. So tell her about this risk. And tell her that additional procedure, like we may need to repair any damaged bowel or internal organ. There is a risk of blood transfusion if there is any bleeding. And as you said, because this patient has BMI 40, don't forget to talk about anesthesia, because there is, your anesthesia will be more risky because of a high body mass index. And within a minute, my colleague who is an anesthetist will come to discuss more about this. Don't go through details, just illustrate that there is a risk associated with the anesthesia. And after finishing the task, tell her, are you happy now to proceed with your operation? So you are obtaining a verbal consent from her. But in the exam, you will not take a written consent. Just close the task by making sure that this patient now has informed decision and make her informed decision about the operation and take the decision of doing the operation after knowing about the benefit and risk. Is it clear now?
Yes, ma'am. Thank you.
Thank you, Dr. Saad. Anyone have any question? Any question before we close the session? Hello? Any more questions?
Excuse me, Dr. Rasha. Can the patient will sign at the same? Patient will. I will ask the patient that she will sign at the same moment, or after she will go to the home and read the pills, and after that later on she can come and sign the consent
It's a really
form.
good question, but look in the trust. That's why I said before, you try in the 2 minutes to know where you are. You are here in the pre-operative clinic. This patient is about to obtain the consent. So, and you will not obtain a written consent. Still, if you have time, because she's about to have the operation. If it is come before and you counsel her, yeah, she will have time to have her decision. But she is now in the pre-operative. She is about to have the operation. She already has the decision, but you are coming for a legal aspect. You need to sign the consent. So you explain already again for her. But this patient already opted. She is coming for the laparoscopy. You got my point? So you need to know where you are. The patient is already planned for the laparoscopy. You are not in the outpatient clinic and explaining to him her options. She already takes the option of laparoscopy and she only about to sign her consent. Okay?
Yes, just I recognize that it is not the gynae clinic. Okay, thank you so much.
Thank you for your question
Dr.
and welcome
Rasha?
all for this session. Yeah.
I'm sorry, ma'am. I think here she checked the score of